Yeah.
That's a big muscle too. So I got that.
Biggest muscle.
It does a lot. Yeah, no, it is amazing how fast atrophy
Yeah,
kicks
so
in.
my quad is clearly not as strong as the other one. But my physical therapist was sort of a joke, so I have to get another physical therapist because the lady I was seeing was like, she'd sit there watching me ride the exercise bike. Are you tired? Yeah. And that would be my visit. She'd sit there watching me ride the exercise bike.
Like everything, there's good, great, and very mediocre physical therapists. Yeah, yeah. So
I have to find a great one.
Organizing
But,
or
no, it's just a stupid thing I shouldn't have done. It was funny because I was the doctor on duty. I had to fill out all my own forms. I had to call in my own accident.
Well, so here's like figure out a time to catch up.
So,
I know, if you're sick here, I guess we'll see.
and I can hear it.
I did it last November for the men's health, and I've done it before, and usually, you know,
She sat at the big table last week. Listen to three kids are here.
what your wife tells you to do, you do.
We don't fight back here.
I don't think people let it hear.
It sounds like I was being tracked down by a million people.
Oh, yeah. The conference. It's the conference.
Drew, what's happening with your life?
I got same old.
At your age, you've already settled into that?
Is that the younger person? Like 4 years ago?
Get beat up by the system sooner or later.
Exhausted. 2 and a 5-year-old.
Because like the ones that had me last year,
That's good. How about you?
Thank you for setting mine.
yeah, that was horrible. So,
Yeah, what do you think?
I was thinking really early until I got hurt.
no, it doesn't hold anything.
My dad's dove right in.
Is he enjoying his?
A week after he retired, he came over to Saturday.
Yeah, no, they lose track of time, days, months.
Every day's a Saturday. So no, he's not looking back.
What was he coming over for? To rock you? I mean, if he didn't think you'd see
The grandkids, wow, they don't care, yeah. They don't care about me. But yeah, they,
Oh, okay, I didn't see that part, but like, it was like,
Did your mom come here or just you?
it's a continuation. They're staying in. I don't know where they are.
They travel.
They're in Connecticut or California. They're going one or the other right now. Yeah,
One of those C words.
one of them. Yeah.
no, so I'm literally just gonna have to, we're all gonna have to sneak out and pay.
He's enjoying it.
My wife retired after she stayed home to take care of me. She doesn't take a smile off her face.
All right, let's go ahead and get started. Everybody take a seat. The reason for this slide is simply I've just been in Italy for the last 10 days, and I just wanted to point out that the mafia is still pretty strong over there. This actually isn't a church that was close to where we were staying near Lake Garda. And there was a big battle there between the Austrians, the French, and the Italians, which actually ultimately led to Italy becoming a nation. Didn't realize this. Italy actually became a nation later than the United States did. It was just independent city-states. So they had this big battle, and this was kind of unusual. A small church close to where the battle took place, and these are the skulls behind the ceremonial part of the church. People who died on the battlefield. 40,000 people died in that battle at that time. So that's got nothing to do with Mike's presentation.
You don't know that.
I don't know that.
Symbolism of the healthcare system is like, oh my God.
So he did the first half of this talk, you may remember, last year, and it was very enlightening. I remember especially some of the things that our pharmaceutical industry does, and we basically bankroll the pharmaceutical production for the whole world out of this country. So I'll be interested to hear the second half of this talk.
Well, thanks again for inviting me. Now, if I go forward, will I get rid of this lovely slider?
More to come.
That's right.
Okay, so U.S. healthcare system.
I flunked that one.
No disclosures, no conflicts of interest. I will say, most of you, many of you know me. I've been practicing allergy clinical immunology for 30 plus years, and so I just started getting interested in this topic over the past few years as I and many of you have seen changes occur, I think, in how you're forced to practice and how your patients are forced to deal with certain cost items that didn't seem to occur previously. So we'll try and figure out why that's happened. So this year's talk is part 2. We're going to concentrate on talking about pharmacy benefits managers, their role that they play in our healthcare system. We'll talk a little bit about medical device costs, which are a world on their own. We'll talk a little bit how health insurance has evolved and comes to influence U.S. healthcare, and then hospital costs. Hopefully we'll have time. A reminder, part 1, as Len said, was April 17th last year, and we talked at that time of how the lack of universal health care in the United States costs both individuals and society. We compared health care costs in the U.S. and other first world countries, and the comparisons don't always come out very rosy for the U.S. And then we did spend the last part of the time talking about the cost of pharmaceuticals currently in the United States. For those who wanted to look at it or missed it or whatever, I included the link to our recording session, so it's recorded and you can go to our UW link and take a look at it if you had a spare hour. So again, this book is pretty illuminating and amazing, and anyone who wants to delve into this in greater detail, I would recommend it. Elizabeth Rosenthal is a physician who ended up starting to get involved in public policy and wrote a pretty interesting book about U.S. healthcare. So in the late 1980s and the 1990s, a new group sort of started entering the medical environment, and this was the pharmacy benefits manager. And today there's only really a handful of very, very large pharmacy benefits managers. There's Express Scripts, there's CVS Caremark, and there's Optum RX, which is affiliated with United Healthcare. And they really have enormous say over what's happening in U.S. healthcare right now. So they're hired by employers and insurers as middlemen to negotiate drug purchases. And that's because antitrust laws, insurers themselves cannot compare prices they pay for medication. But pharmacy benefits managers can, and because of that, they have incredible negotiating power. So they're for-profit companies, and they make money by taking a percentage of the discounts that they end up negotiating. So medications end up on the formularies for your patients, and for ones that you can prescribe are the covered ones in which the PBMs has gotten the best negotiated profit margin for them, period. If they can get a better price for them in terms of a kickback, they're going to put that medicine on the formulary. The ever-changing business deals explains the perpetual churning of medications available through insurance plans. I'm sure all of you have had experiences where 1 year Flovent's available, next year it's off formulary, use QVAR. 2 years later, QVAR is off formulary, we want you to use Flovent. And that's all through deals that pharmacy benefits managers makes with different pharmaceutical companies. And they'll drop medication as a negotiating tactic in order to bring that pharmaceutical manufacturer back to the table with a better offer the following year. I think these go every 6 months that they'll negotiate contracts. With preferred formularies and exclusion lists, the pharmacy benefits managers really dictate which drugs consumers can receive without incurring an additional out-of-pocket cost. So they leverage access to their formularies with threats of exclusion to negotiate rebates and discounts from the world's drug makers, and they take those rebates as profit. Medications go off and on formulary repetitively. Pharmacists tell patients that their medication is no longer covered. This leads to increased calls, obviously, to physicians' offices, which involves nurse staff time, doctor's time, pharmacist time, basically to replace a medication with a different one over and over again. So it's sort of a repetitive cycle. They're used not only by commercial health plans, which I didn't realize, they're used by self-insured employer plans, they're used by Medicare Part D plans, they're used by federal employees' health benefits programs and state government employee plans. So they've really become a huge behemoth in the healthcare sector. As of 2016, managed pharmacy, PBMs managed pharmacy benefits for 266 million Americans. And those three that I mentioned, which comprise 95%, manage pharmacy benefits for 253 people's lives in three companies, basically.
You're not just meaning three people.
A
Three human
company.
beings.
What's that?
It's not three human beings.
No, it's a company.
Yeah.
And it's a big company. And with the CEO, that makes a lot of money.
Yeah.
Mike, you may be getting to this, but how do you think it's going to play out with like CVS owns Aetna now and Cigna's buying Express Scripts?
Yeah, these are huge
cetera.
shifting things that are, I mean, so it seems to be going in one direction, getting bigger and then vertically integrating. And so this vertical integration is happening quicker now because they've gotten as big as they can without vertical
Because somebody did
integration.
it. And then,
Yeah. So they're already affiliated with, some of these, and it's going to get bigger unless something changes. Okay. So beyond traditional claims processing, pharmacy benefits managers are involved in drug utilization review, drug plan formulary development, determining which pharmacies are included in the prescription drug plans network, and deciding how much the network pharmacies will be reimbursed for their services. They also all operate mail order and specialty pharmacies themselves, where patients can get insurances from them. As a result of this increased involvement, pharmacy benefits managements have multiple extremely profitable revenue streams. And each of the three top pharmacy benefit manager teams or companies exceed $15 billion revenue yearly. So put them together, you got $45 billion in annual revenue. They're compensated in three main ways: rebates, administrative fees, and something that's called pharmacy spread. We'll go through each of those. So a rebate is a discount on a medication a drug manufacturer provides to the PBM in return for the PBM covering that manufacturer's drug and putting it on formulary. Since PBMs make the formularies that the plan sponsor will cover, they can negotiate better prices for certain drugs. Often it's a brand name drug, with the PBM making more profit or a larger rebate when there are less expensive or equivalent medications that could be utilized. But if the PBM is making a larger profit or a larger rebate, that other drug will end up on the formulary. Typically, only a portion of the rebates are shared back with the plan sponsor. So the PBM pockets the rest, creating a conflict of interest in terms of profit versus what may be best for the insurer or the patient. It's estimated that approximately 1/3 of the net price paid for prescription drugs is traceable to these rebates, and as a result, consumers are may already be paying 1/3 more for the medication from the rebates alone that the PBMs get. In addition, patients are often forced to switch medications based upon rebates that dictate the plan's changing formularies regardless of efficacy or actual cost. If patients or their providers want the patients to stay on the original drug therapy, as we all know, you're forced to obtain a prior authorization before the PBM will authorize coverage. And in the old days, it seemed to be that if you tried one of these three alternative medicines and the patient had a therapeutic failure being it didn't work as well or they had an adverse event, then usually the PBM would sort of say, okay, you can use the drug you're asking for authorization. But more commonly, it seems like they're saying, no, we'd like you to try all three other medications before we'll approve the one that's on our formulary. Again, because they're getting the largest rebate, the largest profit from that particular drug. They've negotiated that 6 months. It may be a different drug 6 months later. So administrative fees are also another source of revenue for PBMs, where they often charge plan sponsors and manufacturers additional fees and payments at the PBM's pocket. And due to lack of transparency and very complicated nature of drug pricing, it's really difficult for plan sponsors to identify all the charges outlined in their contracts with the PBMs, because the PBMs must have good lawyers. And third, and arguably the most controversial source of revenue for the PBMs comes from what's called the pharmacy spread. So the pharmacy spread is where the pharmacy benefits manager practice, where the network pharmacy, they sort of negotiate what the network pharmacy is reimbursed one price, and the plan sponsor is charged a higher price for the same drug. And the PBM pockets the difference. So the pharmacy gets a certain amount of money, the plan sponsor is paying higher, and the PBM takes the difference, basically. And this has been known in the industry as a clawback. PBMs are able to do this because they negotiate a separate contract with the pharmacy network, and they also have a separate contract with the plan sponsor, and neither are privy to what the other's contract is. So again, pretty good lawyers. Furthermore, the contract created by PBMs with the network pharmacies frequently forbid the pharmacy from informing the patient of a price difference. So they have a contract that doesn't allow the pharmacist to tell the patient if they come to pick up their medicine and pay their copay, that there's a lower cost alternative available if they pay out of pocket for a medication. So they're not allowed by law to tell them that the PBM puts into the contract. Thus, this practice leads to increased costs for the plan sponsor and the patient, while the PBM increases their profit.
Mike, how do they enforce that law? Or how is that law even allowed, that they can't tell them about a cheaper alternative?
I mean, if they do and the PBM doesn't find out, then you've gotten away with it. But if they find out somehow, then there's a lawsuit and people could go to jail.
And that's allowed.
That is allowed. That's the
So
law.
they do have good lawyers.
Yeah. So this practice is estimated to profit the PBMs by hundreds of millions of dollars annually from these clawbacks. And as you sort of rightfully said, how is this allowed? There's now at least 16 lawsuits over the past year to address this conflict of interest, to allow a pharmacist who's supposed to be able to advise patients on various things, that they can save hundreds of dollars if they don't use their insurance and get this medicine and get it, just pay out of pocket, because often it's cheaper, and I'll show you the example of that. So as a result of these revenue sources, PBMs are making billions of dollars a year. We saw that revenues are about $15 billion a year, with little to no federal regulation or oversight. And this lack of transparency and regulation is alarming, given that they manage numerous prescription plans that are funded by American tax dollars with the sole intended goal of reducing costs. So if you want to hit this link on YouTube, it gives you a nice sort of cartoon image of how PBMs sort of fit into the scheme of U.S. healthcare. Again, compensation of the CEOs of the three biggest PBMs is pretty nice. Express Scripts CEO made $15.9 million in 2017. CVS Caremark $12.1 million 2014. Optum RX, again, United, $10.6 million in 2012. In fact, the Optum RX CEO makes the same as the CEO of United, because probably as profitable. So let's sort of go through a scenario or two on how PBMs can affect healthcare costs. So a patient had a TIA, and after she recovered, her doctor prescribed generic blood pressure medication for her to help manage her blood pressure. And she had Anthem Medicare plan, which is Blue Cross Blue Shield in California. And she ordered the medication through Express Scripts, which was her mail-away pharmacy option. And it also was her PBS manager for Anthem. So she ordered it through the Express Scripts mail order service, and she got a 90-day supply for her blood pressure, generic blood pressure medicine that cost her $285 for 90 days. She didn't know any better. So she was about to leave on a trip, and she needed to stock up on medication, but 90 days hadn't passed, and Anthem was not going to cover more of her medication. So during her trip to a local Costco, she asked the pharmacist how much would it cost if she got the prescription there and paid out of pocket. And the pharmacist said, oh, it'll cost you $40.
Did he break the law?
No, because she was not saying she even had insurance. He said, how much does this cost me out of pocket? So $40 for 30 days, so $120 for 90 days versus $285 that was charged to her through her insurance. That Express Scripts got a pretty good rebate clawback from. So this patient's experience of finding a copay higher than the cost of the actual drug actually isn't that unusual. You'd say, well, maybe that's 1 in a million. Well, they did a study, the University of Southern California Schaefer Center for Health Policy and Economics, and they found that the cost of the drug itself is lower than actually the copay costs about 25% of the time. So again, if the pharmacy cannot by law even tell patients that, hopefully that law will change. There are a lot of lawsuits going on right now to change that law. But right now they can't, so you're going to go in, say I've got X or Y insurance, this is the cost of the medicine, and pay it, or do your own research. You can do your own research, but the pharmacist is not going to tell you about the lower cost. There was a 60-minute story that I don't know if some of you saw on Express Scripts within the past year. It was pretty interesting. So the city of Rockford, Illinois had 2 babies on its plan that had a rare disease. And so the medication to treat this disease, Actar, which is just a ACTH analog, costs approximately $250,000 per child per year. So as a result of the city's health plan costs rose so much that it had to start cutting back on other basic services for Rockford. Reduced police force, reduced firefighters. Now, Actar is a medication that's been on the market for decades and used to be very inexpensive. How did it get so expensive? Well, we've heard this scenario a little bit during my last talk. The manufacturer of Actar, Mallinckrodt, I don't think that's how you pronounce it, had taken steps that resulted in the drug's dramatic price increase. They bought the rights for the only competing medication, Sigfussin, which cost $33 in Canada. Then they stopped the production in the U.S. and distribution, and they raised the price of Actar dramatically. Then Express Scripts comes in. So City of Rockford has 1,000 employees, and it's a self-funded health plan, and it uses Express Scripts as its pharmacy benefits manager. As it happens, Express Scripts negotiated a deal with this pharmaceutical company, Mallinckrodt, to be the sole distributor of Actar, and as a result makes more money when this medicine is prescribed. And accordingly, Express Scripts did not try to negotiate a lower price for Actar. That would be lower profit. So the city of Rockford is suing Express Scripts. And during this interview, during the 60-minute story, Express Scripts said it was not contractually obligated to contain costs for Rockford. And the city's attorney said, well, that's the only reason we hired you, is to contain costs. So again, the story's pretty interesting. If you want to see the 20 minutes, I've included the link in this slide here. So now we're going to switch gears to an equally fascinating sort of area of healthcare costs, and that's medical.
I'm just curious, those of you with industry sitting in the back of the room, do you know any of this? Is this, huh?
We get a lot of
You know the company you work for?
Well, these are not. They don't work for PBMs.
No, I know, but I mean,
their companies negotiate, and they get sort of, in some ways, screwed by PBMs themselves. So, yeah.
no, I'm not blaming anybody. I'm just, if anybody knows the background of how this works.
I'll see you guys later. Yeah.
It is what it is. It is what it is right now. So let's talk a little bit about medical devices.
We know where you live.
I
just started.
It's an even wilder west show when it comes to medical devices. So medical devices are frequently the biggest item on a medical bill. It usually costs many thousands, if not tens of thousands of dollars. So they're often more than the surgeon's bill. They're often more than the total of the 3-night stay at the hospital. They're often more than the total charges of all the medications dispensed during that in-hospital stay. And medical devices essentially have no real price. They're essentially made-up prices, right? You know, it's true. So for a hip implant, the cost chain includes the joint implant manufacturer, the joint broker, the joint distributor, the joint device salespeople, and the purchasers, either at the hospital or the surgical center. Each year, more people get involved, and each takes either a commission or adds a markup as the device moves along the road from factory into the body. So the sales representative takes between 16 and 18%. The distributor does a little better at 30%. The hospitals then take a little bit more at 100 to 300% over the cost. An orthopedist who's trying to start a company for generic devices estimates it would cost about $350 to manufacture either a hip or a knee implant in the United States, and about half of that if they manufactured it overseas. So $350 at most, and maybe $180 if they manufactured it in China. But if you look at some patient bills, you're going to see some different numbers. $36,800 for a metal alloy knee that was implanted at New York University Hospital for joint disease. $4,000 bill for screws used in the back operation at Lenox Hill. Close to $33,000 for an external fixator, which is a stabilizing rod screwed into the bone to help heal a child's fracture after he was hit by a car. Contrast this if a device maker sales representative opens the wrong size device for a total hip replacement. They open the medium and he should have opened the large. He's going to be charged a whopping couple of hundreds of dollars for wastage. So the cost is a couple of $100 and the bill is for $36,000. Okay. So they're a very tight-knit oligopoly that has pretty much absolute control over distribution. There are dozens of big pharmaceutical manufacturers. There's hundreds of small pharmaceutical companies, but there's only a very small handful of huge device manufacturers that dominate the market. And experts jokingly call them the cartel.
Do you know where those are manufactured and what other countries do? Or China doesn't pay that?
I don't know that, Drew. Yeah, I don't know what the cost in other places are. I know in China they probably have their own, knockoff.
But there's such big tariffs. There's such big tariffs on it now. You might cost billions of dollars.
So if you look at some of the largest medical device companies, I have listed here their revenue in 2018, and then the CEO's compensation. So Medtronic, pacemakers, a few other things, close to $30 billion in annual revenue. The CEO makes over $15 million a year. DuPont Synthes, which is a subsidiary of Johnson & Johnson, revenue $26.6 billion. Their CEO makes $21.2 million a year. Cardinal, $13.5 billion revenue. CEO, $10.9 million annual in compensation. Stryker does a lot of hips and knees, 12.4 billion in annual revenue. Their CEO makes 14 million. He has a pretty good deal compared to the others. Their company makes less, but he makes more. Pretty good. Part of the original Affordable Cares Act was a medical device excise tax of 2.3% that was designed to help finance the Affordable Care Act. The companies, the medical device companies, went ballistic, and they spent $32.8 million on lobbying to fight this medical device excise tax. It just so happens that Minnesota and Massachusetts have a lot of insulin pump manufacturers, and so liberal senators like Al Franken, Elizabeth Warren, and Amy Klobuchar worked with Republicans across the aisle to defeat the medical device excise tax. So the top donations of this went to Al Franken and Amy Klobuchar during this sort of lobbying campaign. And they were successful in getting the medical device excise tax of 2.3% suspended for 2 years in December 2015. This 2 years savings of 2.3% was estimated to save $3.4 billion for the companies because their revenue is in the range of $150 billion annually. So that was a pretty good return. Spend $32.8 million and save $3.4 billion in 2 years. So you can understand why people lobby. You can sort of understand why liberal people take the money because it's jobs in their state. But you know, the whole lobbying sort of stuff is part of where healthcare costs go up.
I think
Did it go into effect?
Well, I think well of all of those people, but when it comes to state, that everything is local, right? Politics are local.
Did it go into effect in 2017?
Yes. Yeah. It's probably been removed. I think it's one of the things that our current president has stopped. But it was there for a couple of years. So healthcare, health insurance industry, it's very interesting how health insurance industry evolved in the United States. It's pretty fascinating. It's probably the original sin that got the U.S. sort of very different than every other country and started the evolution into today's medical industrial complex. The founders of Blue Cross in Texas nearly a century ago had no idea how their innovation would spin out of control. They initially intended it to help the sick, and in the beginning it did for sure. 100 years ago when it was started, medical treatments were pretty basic, cheap, and not very effective. Hospitals were sort of places to go to either convalesce till you healed on your own or you died, and they were often run by religious charities. So they didn't have antibiotics, they didn't have non-steroidal medications, there were no anesthetics, there was no minimally invasive surgery. So sickness and injury took either, again, a long time to heal or to not heal. The earliest health insurance policies were designed primarily to compensate for income while workers were ill and they lost their revenue from work. So insurances were offered to local teachers unions very early on for $6 a year, 50 cents a month. And for that, the teachers were entitled to a 21-day stay in the hospital, which cost $5 a day, all costs included. But there was an elimination period in that their insurance didn't go into effect until 1 week was done. So it was pretty cheap, and it seemed to work pretty well at that time when costs were so low. And within the decade, this model spread all across the country from Texas. 3 million people signed up by 1939, and the concept had been given a name, Blue Cross plans. The goal was not to make money, but to protect patient savings and keep hospitals afloat. And Blue Cross plans were then not-for-profit. And again, the hospitals were charitable organizations at that time. But then transformative technologies evolved. Thankfully. Abbott Labs developed and patented the first intravenous anesthetic in the 1930s. Massachusetts General started the first anesthesia department in 1936. First ICU with ventilators opened during a polio epidemic in Copenhagen in the 40s. And it became very clear $5 a day and the 21-day maximum stay was no longer going to cut it. The National War Labor Board for a while froze salaries after World War II, during and after World War II, and companies faced labor shortages. And so they found they could attract workers. They couldn't offer them more money because of the freeze by offering them instead, in addition to their salary, health insurance. So the federal government ruled that the money paid by employees' health plans would not be taxed, and this seemed like an initial win-win strategy in the short term, but in the long term had some sort of negative implications. So again, the original purpose for health insurance was to mitigate financial disasters brought on by serious illness, and it was never really intended to make healthcare cheap or serve as a tool for cost control. So Blue Cross and its partner Blue Shield were more or less the only major insurers at the time, and Blue Cross covered major medical hospital, Blue Shield covered doctor's visits. Between 1940 and 1955, the number of Americans with health insurance rose from 10% up to 60%, and that was before there was any Medicare or Medicaid, so this was all commercial at the time. 60% had commercial insurance by 1955. And the name Blue Cross Blue Shield became ubiquitous as a force for good. According to their charter, they were not-for-profit. They accepted everyone who sought to sign up. All members were charged the same rates, no matter how old or sick they were. Sort of sounds like universal health care almost. Blue Scouts handed out brochures. Preachers urged their congregations to join. But the new demand for health insurance presented a business opportunity, and it spawned an emerging market that had other motivations. And so for-profit insurance companies moved in, and they were unencumbered by the Blues' charitable mission. These companies, for-profit, accepted only younger, healthier patients on whom they could make a profit. They charged different rates depending on factors like age, as they had done long ago from life insurance. So these were life insurance companies moving into the health insurance market. They produced different types of policies for different amounts of money, which provided different levels of protection. Aetna and Cigna were both offering major medical coverage by early 1950s. With aggressive marketing and closer ties to business than to healthcare, these for-profit plans slowly gained market share in the 70s and 80s. And the Blues still had to worry about their mission of providing high-quality, affordable health care to all. And by the 1990s, the Blues were hemorrhaging money and getting set to go bankrupt because they had to cover only the sickest patients that were left after the for-profit insurance companies cherry-picked the younger, healthier patients. Again, something that the Affordable Care Act tried to get away from by forcing everyone, even young people who were healthy, to sign up and have health insurance. So in 1994, the state directors of the Blues rebelled, and the Blue Board relented and allowed member plans to become for-profit insurers, ending the not-for-profit status of Blue Cross Blue Shield in 1994. So the primary motivation was to gain access to the stock market, raise cash quickly to erase all the deficits that they had built up leading to that point. So this was the final nail in the coffin of the old-fashioned, noble-minded health insurance. Health insurance's focus changed from the patient member or even the company and unions, and now the focus was clearly on shareholders and investors. In 2010, WellPoint, which is now called Anthem Blue Cross of California, intended to hike premiums in California in 1 year 39% before the Attorney General stepped in. The WellPoint CEO still received a pretty nice compensation, 2012 of $20 million. In 2014, WellPoint enacted its plans and changed its name back to Anthem Blue Cross, presumably to take advantage of the nostalgic, good feeling patients had retained toward the Blues before they went ahead next year and raised their premiums 25%. In 1993, before the Blues were for-profit, insurers paid about 95 cents out of every dollar of premiums on medical care. But once they became for-profit, they had to increase profits and all commercial insurers, regardless of their tax status, have been spending less on health care in recent years and more on things like marketing, lobbying, advertising, big executive compensations, and paying out their stockholders. So commercial insurers now spend, instead of 95 cents on every dollar on health care, now they spend 80 cents of every dollar of premiums on medical care. And this again compares back to my talk last April on Medicare, which spends 98 cents of every dollar on health care. So over the past decade, I think many of you, if you have your own personal health insurance, or if you talk to your patients about their costs, health premiums, insurance premiums, and deductibles have both been rising incredibly fast. From 2005 to 2015, one decade, average health insurance premiums for family coverage increased 61%, and the workers' part of that contribution increased even more, 83% in a decade. Deductibles are rising even faster, and between 2010 and 2015, 5 years, deductibles have risen 67%. And the rate of increase for both of these way outpaces both inflation and the increases in workers' wages, which we know have been relatively stagnant in this period. In 2005, the average annual premium for employee-sponsored health insurance was a little over $8,000 for family coverage. And then in 2015, the premiums more than doubled, where the average is now over $17,000 for employee-sponsored family coverage for premiums. In 2009, only 22% of workers were enrolled in a plan where they had an annual deductible of $1,000 or more. 6 years later, that number was up to 46% of workers were enrolled in a plan with an annual deductible of $1,000 or more. So premiums are up, but we're paying less. Now, if you want to look at health insurance CEOs, compensation in the Affordable Care Act era, they're pretty staggering. United Healthcare CEO made $279 million annually. This company, I don't know if many of you are familiar with Centene. I was not. I said, what do they do? And what insurance is that? That guy's making $170 million. They do contracting for a lot of TRICARE, for different Medicare plans. They contract and run Amber Care. I don't know if any of you are familiar with Amber Care. It's one of the ones on the exchange. They pay physicians rates that are like DSHS rates, so like 20 cents on the dollar, but the CEO makes $170 million a year. Cigna, Aetna, Anthem, Humana, you can look at the numbers yourself. I don't have to read them off. One that is sort of interesting is Mario Molina, who started Molina Healthcare. And again, I don't know if many of you are familiar with Molina, but it's a private company that basically manages exclusively DSHS patients or Medicaid patients throughout the country. And again, if you as a physician are seeing a Molina Healthcare patient and you bill $1, you're going to get 20 cents back. It's not going to be enough to keep your office lights on. It's not going to be enough to pay your rent. It's not going to be enough to pay your staff. But Mr. Molina is making $42.8 million a year. The only good thing is in 2017, for reasons I have not yet figured out or read enough about, he was fired off of as a CEO of Molina. So I don't know if it was just for making too much money or doing something else. He was fired. So again, pretty staggering numbers. Okay, good. Hospitals. Cost of hospital services has grown faster than costs in other parts of the U.S. healthcare system. Between 1997 and 2012, not that long ago, the cost of hospital services grew by close to 150%. The average hospital cost per day in the U.S. in 2013 was $4,300 per day, which was about 3 times more than Australia and about 10 times more than it cost in Spain. Most hospitals, not all, but most hospitals are not-for-profit. So therefore, excess income needs to be spent at the end of the year. You can't distribute it to shareholders. So they give it to executive compensation, and they build pretty nice buildings, fancy lobbies, really nice facilities that people like to go into. There's an army of hospital consultants designed basically to improve revenue, improve compensation, and get a bigger part of the business. And about 10 to 15% of the revenue goes to billing and collection companies that are contracted to do things like claims and pre-approval. These sort of jobs don't exist in Europe and Canada, any other place that has universal health care. Because patients really were no longer directly paying for their care because insurances were taking over, hospitals began charging more for their services and just expecting the insurances to pay. The original blues paid by the week for hospitalization, now hospitals charge for each service and each encounter. And the good times were rolling in for hospitals between 67 and 83 when basically hospitals set their rates and the patient, or more likely the insurer, was expected to pay. Medicare payments alone to hospitals increased from $3 billion to $37 billion from 1967 to 1983. And finally, in the mid-1980s, Medicare had enough, and they switched from paying what was billed to paying according to a DRG, or a diagnosis-related group. And that's basically saying, okay, for an appendectomy or for a pneumonia or for X or Y or Z, this is the number we're paying, whether they stay in for 2 days, whether they stay in for a week, whether they stay in for 2 weeks. And so now the incentive was not to do, was to get them out. It's because they were getting their money whether they got out in 1 day or 1 week. So the hospitals would now make more money if the patient, quote, healed more quickly and efficiently, and would lose money for those who did not. Commercial insurers never adopted the Medicare DRGs, but they also started to balk at paying whatever the hospital was charging. And so they hired case managers to review, approve elective surgery, as well as to negotiate and determine what proportion of the bill they would agree to pay. So if anyone's had an MR, anyone's been in the hospital and had anything done, you see the bill, and then you see the negotiated price, and it's like a crazy difference. And then the insurance basically says, we've saved you so much money, don't you love us? You know, this sort of thing. So this is how the gap between the big numbers on hospital bills and what any actually insurer pays began. It started as a little bit, and then it evolved into this huge dichotomy. There's really no such thing as a fixed price for any procedure or test. You can go to different places, get the same thing done, and be charged totally different numbers. Some absurdities, I mean, you've probably heard a number of your own, but a couple of examples of absurdities in billings in the United States. $17 charged for a pill of Tylenol. A family was billed $21,000 after their father had a heart attack in his living room. He was driven by relatives to the hospital, only to be declared dead in a wheelchair in the lobby before a single test was done. How that warrants a $21,000 bill, beyond me. I don't know how you sleep at night. A Canadian who wintered in Arizona was charged $210,000 for a failed attempt to take out a hip implant that had become infected. He got another bill for $28,000 when he was airlifted back to Canada, where they took out his infected hip for free. So there's a lot of absurdities here. Upcoding occurs very often, unfortunately. You can inject a knee with steroids, and if you code it as surgery, you can bill for $1,200. If you use ultrasound to guide the needle, which is not necessary in the knee, it's a pretty big joint, you can charge an additional $300. So people who want to, and most people don't, but people who want to can really run the system. Hospitals add charges for the use of its rooms and equipment, which they call a facility fee, which is added to the cost of every bill for both in and outpatient encounters. And I've had a number of facility fees when I've gone to visit people that seem sort of ridiculous. I have some of my patients who are on Medicare, and they're getting an anti-IL-5 subcutaneous injection at a local public hospital. This hospital is paid by tax dollars, and those patients get charged $650 for a subcutaneous injection by the hospital, in part due to the facility fee. I've had one of my patients had to take a GoFundMe account out and have friends and family members fund her so she can pay for her $650 sub-Q injection. That's not the medicine, that's just the injection at a local hospital that I can tell you what it is if you'd like.
How much of this, though, is just the hospital trying to stay afloat in an environment where
I'm sure they tell you that.
Well, I'm just curious.
I don't know. I'm sure that would be the party line. We got to do that, and we can do it, right? I mean, you see the same patient and do the same thing. Well, you actually get to charge a facility fee. But if we see the same patient and do the same thing, on addition to whatever your E&M code and everything else you puts on a facility fee. I would go to jail if I put on a facility fee for doing the same thing. So, and I don't know what the law is, why it is, but it is. And I'm sure they'll say we need to do that because we're taking care of indigent patients and we're doing this and we have to build this next facility. And yeah, I'm sure there's a reason that someone will give.
I'm not defending them. I know who's ultimately the problem here. I don't know.
Yeah. Well, okay.
All of the above.
I don't know if you're going to have time, but how did we get to be so different than the rest of the? None of this exists in the rest of the world, which is delivering excellent care. You just told us about Canada and Spain, and they're capitalist countries also. People want to make money.
Right. Well, it was an interesting Northwest Allergy Forum this weekend. One of the talks was a Canadian orthopedist surgeon who has dual citizenship and lives and practices part-time in Tacoma and lives and practices part-time in BC. So he contrasted the two systems. And so there are some real issues with the Canadian system that we do better, and there's a lot of issues in our system where Canadian and European and other countries do better. A friend of mine is head of pediatric respiratory at Karolinska Hospital in Stockholm. So it's probably the biggest hospital in Stockholm. And so takes care of all the asthmatics, all the respiratory folks in Karolinska Hospital. And they're allocated 15 people on Xolair per year. Can't go to 16, 15. And so they try and figure out who needs it the most. They then try and split doses to see if they can get by with half. So they do a lot. So it's not all perfect. Yeah. It's a complicated issue. So hospitals love to, embrace high return items. So obesity rates climb. Medical equipment companies devise some new operating uses and new procedures to help combat obesity, and bariatric surgery became a booming field. Companies, hospitals, doctors groups all lobbied successfully to have insurers pay for this, so being overweight was rebranded as a disease. And hospitals within a few miles of one another started to invest very heavily, though maybe that's why they have to charge a facility fee, because they're investing in lucrative bariatric wards to buy new beds, lifts, wheelchairs, and OR tables that could accommodate the bulk of the patients that were coming in for these procedures that had very good returns on the procedures. One other example, proton beam therapy was developed to treat a small number of tumors that were hard to reach by other methods. But manufacturers of the newer, higher energy machines costing over $100 million had a bigger market in mind. And originally, experts predicted that there would be at most a handful of these machines scattered around the U.S. where patients could fly to if their tumors could not be otherwise treated. But once they found out Medicare was reimbursing pretty generously for this new procedure, In short order, proton beam therapy was being used on a far wider range of tumors than had ever been intended, despite little evidence that it was superior to cheaper options. Every hospital wanted their own proton beam machine, came with the billing tips as well as how long it would take to recoup the investment. The NCI and American Cancer Institute tried to tame this with science, but that didn't work. They did a study of 30,000 patients with prostate cancer, found that proton beam therapy provided no long-term benefit over traditional radiation therapy, despite far higher costs. But bankers regarded this purchase as a safe investment, and they were approaching hospitals and offering to finance the machine if the hospital wanted to build one. Companies sprang out to help smaller hospitals broker, build, and install a proton beam machine. There was one company, Procure, that received $100 million from equity funding to do this sort of approaching of smaller hospitals. If a British citizen needs proton beam therapy, they send them to the US for treatment. They pay for travel and 8 to 10 weeks of lodging rather than build a machine. If there's one machine in all of Canada. In 2018, there are 3 machines in Washington, D.C., 4 machines in Florida, and 2 in Oklahoma City, as well as having our basketball team. So I think hospitals now actually hire hotel executives to consult on how to make their hospital lobbies and rooms and everything like hotels. Patients rate these fancy hospital experiences better, and Medicare pays hospitals a bonus for performing well on patient surveys. Even if there's no evidence that the healthcare is better, but the survey said I liked my experience better, I had a private room, the lobby was lovely, they played piano music in the lobby, it was just lovely. So there's reasons to do that to attract patients. In most cities, the highest paid not-for-profit executive runs the local hospital. In 2012, CEO of Pittsburgh, $6.1 million, Cleveland Clinic, Cedars-Sinai in LA, New York Presbyterian. Even small community CEOs earn around $2 million a year. You look at Providence, which had initially was started by nuns and physicians, paid its CEO in 2013 $3.5 million, although it still describes itself as a not-for-profit Catholic healthcare ministry, continuing a tradition of caring that the nurses of Providence began more than 158 years ago. And to some degree, I'm sure that is true. So, suggestions. These are just my thoughts after reading and thinking a little bit, and it has nothing to do probably what's going to happen. I think there should be Medicare for all. It makes no sense to do it otherwise in my mind. That would make it universal coverage with the option, as many countries do, to buy additional insurance if you're not totally happy for the Medicare for all coverage. And so you can buy additional coverage that gets you in faster or gets you certain things that maybe Medicare you'd have to wait for. This would totally eliminate personal bankruptcy due to medical illnesses, which we talked about in April, the high rate of personal bankruptcy due to medical illness and hospitalization in the United States. So no country with universal coverage has any personal bankruptcy due to illness. I don't see any reason, since every other first world country does this, why we don't allow Medicare to negotiate prices for pharmaceuticals, medical devices, hospital costs, physicians, they already do for physicians, PT, they already do for physicians, and every other cost. And hopefully this can eliminate the need for pharmacy benefits managers if Medicare can negotiate directly. I think we need to change patent laws so we definitely incentivize innovation, but not allow companies to buy competing medications with the express plan to discontinue the cheaper medicine and then by default jack up the price of their monopoly medicine. And we should definitely do what every other country does, is have costs for medications go down, not up, the longer they are out. Once you reach expiration date on your patent, medicines go down in every other country, but in the United States, they just keep going up. We've talked about many examples. Last April, insulin developed in 1923, given away essentially by Banting and Best and the University of Toronto. 10% a year rise in 2015, 16, 17, 18, a medicine that's been available for a heck of a long time. And if these things don't happen, I don't see why we shouldn't allow easier access to cheaper medicines from Canada and other pharmacies in other countries where medicines are generic a lot sooner and people seem to use those medicines without falling dead. I mean, the thing is, FDA hasn't guaranteed this medicine, and you can't prescribe a medicine to a patient from Canada. I don't see Canadians dropping dead from bad medicine. So that's my sort of superficial thoughts. And then to end, finally, I just came back from Peru, and this is sunrise over the Andes Mountains from Machu Picchu. Pretty spectacular range of mountains. A few minutes later, this is the light sort of bathing Huayna Picchu, which is the peak that overlooks down below. Machu Picchu is still sort of in shade, and Huayna Picchu is starting to get the sun. About 2 hours later, we were at the top of Huayna Picchu. This is now looking down at the Machu Picchu complex. Myself, Leslie's sister Claire, and her husband Chip. Pretty fantastic place. If you haven't gotten there, Peru's pretty cool. So thanks again for your attention, and if I can answer any questions, I will, but it's a pretty complex field with a lot of interesting laws and interesting things that happen to sort of change how we can deliver what we hope is the best health care for our patients.
Almost makes It's absolutely brilliant, Mike. And really thank you for delving into this. Just eye-opening to me. Almost makes me embarrassed to be a part of this system, unknowingly. Trying, all of us here, trying to be thoughtful, caring physicians and to somehow be participants in essentially extortion.
Well, there are parts that have gotten out of control, and when you put things for profit, when you have, stockholders and things like that, things don't get exactly aligned when it comes to healthcare.
The ecotourism stuff, medical tourism is becoming obviously big business, but they had an article about a hip replacement in India. And basically what they do is they have the staff orthopedic surgeon work with all the residents. So they do the opening and closing, and the staff guy comes in and puts in the prosthetic and then moves from room to room. So it costs $1,500, including hospitalization, for a total hip replacement in India. And their infection statistics are way better than the United States.
Right.
So you can fly to India, have the whole thing done, fly home for about 1/10 the price of getting it in a U.S. hospital.
Yes, that's being done more and more. You're absolutely correct.
And that just should be a wake-up call that our system isn't as good as we think. And like Len said, I don't know the word extortion I would use, but pretty much that's what's happening.
Yeah. And again, when you look at some, I know you were, I think, dealing with your injury last April, Paul, but when I gave my talk in April, we talked a little bit about how we rank compared to other countries in terms of infant mortality and cost per capita and all these things, and they don't look good.
No.
They don't look good.
I think
and people do go to other countries for living in retirement for cost, but also for medical reasons. And when things go well, I think you said I made the best decision in the world. And when you're in that, 2% that get infected or have a complication, you said, what the heck did I just do? So.
Well, they had another article about a colonoscopy in Chicago, and the top price for a colonoscopy in a hospital outpatient was $2,800. And some GI doc agreed to do it in his office, in a little suite they have in their office, for $185.
Yeah. I mean, I think if you keep your eyes open and read papers and New England Journal and watch TV, there is probably not more than 2 days that go by that you're not reading something about healthcare or healthcare costs in the U.S. and how some craziness is, going on. And I think the thing that blew my mind probably more than anything is, it costs a couple of hundreds to make a hip or a knee, and that's what the guy would get charged if he opened up the wrong size. But the bill is $36,000 by the time it gets through all these chain of people who do absolutely zero for healthcare. Yeah.
What's your suggestion that we can do? I mean, as Len said, we're sort of all in this business, whether we like it or not. What can we do to help change this?
Well, Mike just did a lot.
No, I mean, do we send Mike on the road? I mean,
Well,
maybe
he
we should.
just educated us at
Right.
least.
That's the start, but
there
I
are
mean-
participants in this
I mean,
chain of
ultimately, the only thing that can change this system is if you vote for congressmen and senators who will
Address it.
change the system.
Right.
Because if you don't, and again, I've always felt personally, which I think will never happen, is that you can't have a lobbying class of people. I don't know how many people living in D.C. are lobbyists. Because they have one agenda, they write the bills half the time for the Congress people to just sign and present. They don't even know what they're signing. The lobbyists have written it for their particular industry, and it's not just healthcare, it's everything, right? But the lobbyists also pay the senators and Congress people and governors basically money for their race, right? So it gets very complicated. You have to have, no lobbyists, you have no donation, but the Supreme Court has said you can donate as much money to anyone as you want without declaring it. There's a lot of change that has to happen before anything good will happen here. It doesn't mean it can happen. It may have to collapse before that happens.
So, pardon me if I speak out of turn. So I am a physician. My background was general surgery, and now I work in industry.
Yeah.
And I think we all have a sense that physicians lost their seat at the bargaining table as these became big for-profit behemoths. And being on the industry side, I was both in a sort of device company in that nebulous human cell world, and now in pharma. I've been in those national Kaiser meetings looking at product categories, and it's really interesting that they say they'll invite their physicians, and the physicians weigh in, and they have no real power in terms of the decision making. So when you're going up against for-profit insurance companies, it's interesting that the only behemoth that can push back is pharma, because they're the only ones who may be able to go in and say, yes, this medication costs more early on, but long-term patient savings, physician advocacy. I'm not saying the industry is great. I haven't been in long enough, but it's interesting to see that you kind of have to partner with the devil at the moment, push back, and I've always thought it was the for-profit side, because you can't do healthcare for-profit, right? That's sort of against the tenets of the practice. That there's not a clear solution, but if you push back against insurance companies, maybe that falls downstream as well. That's just it's a viewpoint I've only developed over the last couple of years.
Sure. Well, it's very complicated, obviously, and who thought it would be complicated? Not Donald Trump. But yeah. So I think if we got to Medicare for all, would be obviously tax dollars have to pay for that, so tax dollars have to go up. But I think Bernie Sanders did the analysis right or wrong, saying that tax dollars go up, but all these premiums go away, all these deductibles go away, all these other costs go away, and you pay for it, basically. But then you have a whole group of other people saying you're a socialist communist, and we don't do that here, and there you go, So it's... Yeah, what we could do, I don't know, as a group, we're not even allowed to compare what we get for doing the same thing. That's, antitrust. Where the insurers do it all the time, because I've been negotiating for our group with insurers, and, they will say, okay, we'll make this change, and the change happens to equal exactly what the other they've been underpaying us, so then they come up to exactly what the other insurers have been paying us. No, not a penny more. They know exactly what we're getting, but we're not allowed to, I can't talk to Bill and say, how much are you getting for seeing an asthmatic? That's complicated. So it's, there are some things stacked against, but I think we do what we do, which, each day trying to make the lives of our patients better, and then hopefully legal stuff, and Congress and senators over time will see the light, although they seem to have pretty good health care coverage through the government. They just don't want other people to have government health insurance.
Yeah, one of the more distressing things was people who I highly respect as liberal Democrats who should be right-minded. The point you made, if their state has an economic stake in a law, they'll vote the wrong way anyway.
Well, again, not to digress, but, military doesn't want this tank, but, the state senator wants the tank, so the tank is in the military budget. The military says, I don't want that tank anymore. It sucks. It's, but it's still in the budget because the senator doesn't want to lose jobs in his state, that are making the tank. So, so there's a lot of stuff that happens that we all know about. But anyway, since healthcare is what we do, I thought it was useful to enlighten myself and try and pass on a little bit of what I learned here. So at least we know when your nurse is calling for the 5th time to get a patient a medicine that they were on 4 years ago, then we're taken off of, and now they're back on, why that is so.
Well, Mike, we have to have you back next year, and I hope next year something is more optimistic. You can say something encouraging has changed.
We have to have you run for congressperson.
Vote for Altman.
Absolutely fantastic, enlightening talk. Thank you very much.
Is there